Hello, everybody. My name is Brad Needleman. I'm a bariatric and foregut surgeon at the Ohio State University Wexner Medical Center. I'd like to thank Doctors Now and Majid, as well as Sages, for the opportunity to speak today. Sorry I missed everybody in Cleveland this year. Hope to catch up with everyone at Sages 2021. The title of my talk is To Wrap or Not to Wrap a Patient with Obesity. Here are my disclosures. They're talking about obesity and patients and when to wrap. Things I wanted to talk about today was that reflux actually may be a little bit different in the obese population than we might see in folks with normal weight. Whether or not to wrap a patient with obesity is not necessarily straightforward. There's data that exists that both supports and refutes whether or not you should wrap patients in the obesity. I think the literature on reflux and wraps defines BMI as greater than 30 as obesity. So looking at the literature, it might not be unclear what to do with a patient with a BMI of 40 or 50 or 60 or 70. The other things I wanted to talk about, I know there's another talk about this as well, that a Roux-en-Y gastric bypass is a very good and durable operation for reflux, but not only for reflux, but it's also good for weight loss, diabetes, high blood pressure, fatty liver, sleep apnea, etc. And that there is a 2020 SAGES white paper on the surgical management of GERD in obese patients, and feel like when Dr. Now is the first author on that paper and he invited me to speak, he should have disclosed that to me when he asked me to give this talk. So GERD in patients with obesity. So what's different about GERD patients with obesity? There are multiple studies out there that show that esophageal acid exposure time and reflux symptoms do link positively with BMI. And here are some of the things that I found, as well as the references for them as well, that abdominal pressure is increased in obese patients, and there's a direct correlation between pressure, BMI, and waist circumference. For every 5-point increase in BMI, you can also find a 3-point increase in reflux score. A meta-analysis identified significant associations between increasing BMI and erosive esophagitis. And increasing BMI is significantly associated with the increase of adenocarcinoma and the esophagus and cardia. So what's the cause of reflux in obese patients? How is that different? We've identified there is dysfunction of the lower esophageal sphincter. The low resting pressures or decreases in lower esophageal sphincter pressures are secondary to sphincter shortening that could be due to gastric distension in this population. There's delayed gastric emptying and esophageal emptying. This could be from the high incidence of diabetes in this population, or could just be idiopathic in obesity. The increased intra-abdominal pressure of obesity also increases gastric yield pressure, as well as the increased axial separation between the lower esophageal sphincter and the phreноesophageal ligament. And together, those two things are really factors that create a pressure gradient at the crura that results in progression of hiatal hernias and may even make GERD worse. Also, sleep apnea, which is very common in patients with obesity, can lead to the collapse of the upper airway and the development of a more negative intrathoracic pressure. And this transdiaphragmatic pressure gradient is higher in obese patients, and prolonged periods of nocturnal acid exposure is not uncommon in these patients as well. So what do you do with these patients when they have reflux? Data is confusing. I just was coming across doing my literature search. Here's one paper in 2001, obesity adversely affects the outcome of anti-reflux operations. And then 2 years later, obesity does not adversely affect the outcomes of laparoscopic anti-reflux surgery. So basically the same paper, the same title, just the complete opposite of one another. So wraps can be done in patients. Here's the evidence that I found that supports the outcomes for wraps are similar in patients with obesity, without the obesity. So here's a paper. Obesity does not adversely affect the outcomes of laparoscopic anti-reflux surgery, the paper that I just showed. It was about 505 patients with a body mass index of less than 25, 25 to 29, and 42% were obese, or a BMI greater than 30. Although the operative times are longer in the obese groups than the normal weight groups, the rates of anatomic failure were similar among the obese, overweight, and normal group patients. And their conclusions were that although the operative time is longer, complications and failure rates are similar to those in non-obese patients as obese patients. And obese patients have equivalent symptom relief and are equally satisfied post-operatively. and therefore obesity should not be a contraindication to laparoscopic anti-reflux surgery. And instead of giving you all the papers, these are papers that all had similar conclusions. So there were 4 papers, 2005, 2009, 2015, and 2017, all came up with similar conclusions. A little longer operative time, complication rates are the same, and they both have good symptom relief after surgery. I will say though, just like this paper, BMI of 30 or over is considered obese, and very often the average BMI on these patients was about 33. Here's a more recent paper, 2014, retrospective review of patients undergoing reoperation for failed anti-reflux surgery. There were 109 interventions in 95 patients. Basically, what this paper showed was that obese patients were much more likely to fail due to a slipped wrap than patients who are not obese. So they concluded that obese patients with a recurrence after a failed anti-reflux operation may be safely treated with a repeat operation. There's no difference in outcomes for patients with a BMI greater than 30. And it's important in preoperative discussion, the best approach to have a reoperative fundoplication or a gastric bypass. But again, the outcomes in these patients were pretty similar, except that obese patients were more likely to fail via a slipped wrap. Another paper from 2020 in surgical endoscopy, so very recent, the role of body mass index in determining clinical and quality of life outcomes after laparoscopic anti-reflux surgery. And again, this is a large number of patients, 869 patients, divided into sort of normal weight, overweight, obesity class 1 and class 2 and 3 obesity. So a little bit, 114 patients with class 2 and class 3 obesity, so a little bit more than we've seen in some of the other studies, looking at the usual things that we'll see after gastric bypass. A little more different complications, or a little different complications in the different obesities related to arrhythmias and UTIs were definitely more common. But basically everything else was pretty much the same. So these findings suggest that laparoscopic anti-reflux surgery in overweight, obese, and morbidly obese patients, when compared to normal weight cohorts and short-term follow-up, have similar value in addressing pathological reflux manifestations and conveying quality of life benefits without added morbidity or mortality. So again, supporting that you can do wraps in patients with obesity and have similar results to those of normal weight. Another study looking at BATSM index of greater than 35. I included this study because it specifically looked at patients with a higher BMI, those greater than 35. Like I said, most studies that we've looked at are really looking at patients with an average BMI of less than 35. But again, looking at 70 patients that they followed prospectively with a mean BMI of 38 who underwent Nissen, and then compare them to 70 sequential non-obese patients with a BMI less than 35 who underwent Nissens. There was basically no difference really between these two groups, and morbid obesity did not adversely affect the outcome of Nissen fundoplication, and conversion rates are low and performed by an experienced surgeon. So another study showing that Nissen fundoplication with BMI greater than 35 again has similar results to those who are not overweight. This is from my own institution. Dr. Perry does one of my partners who does a tremendous amount of bariatric surgery, of foregut surgery, great foregut surgeon, laparoscopic Nissen fundoplication, controls reflux symptoms and improves disease-specific quality of life in patients with class 1 and 2 obesity. 176 patients divided into the different classes, as you can see there. So 47 patients with class 2 obesity, BMI of 37 or greater. Looked at the typical things that we see and really found that Nissen fundoplication provided similar symptom control and quality of life 18 months post-operatively in non-obese and class 1 and class 2 obese patients. And there definitely recommends a Nissen as a viable surgical option for patients with class 1 and class 2 obesity. This is yet unpublished data from him and my same group at Ohio State. This was submitted to DDW, not yet published, but I wanted to include this because it shows, again, different BMIs of 35 to 40, but more importantly, he has 6-year follow-up. So compared to controls, obese patients exhibited comparable improvements in disease-specific quality of life and high satisfaction rates 6 years following Nissen fundoplication. So this is really the first one that I've seen that really shows durability of these operations in obese patients versus normal weight patients who have RAPS. And then although the patients with class 2 obesity reported higher use of PPI, there wasn't a difference in the increased risk of reoperation within those two groups, and definitely durable reflux control in obese patients as well. So I think I thought this was an important study to include because of that really long-term follow-up that you typically don't see in reflux literature. So there is some literature also, although I would say that the preponderance of stuff that I found was that RAPS in those patients are pretty much okay. Here are some studies that show that the outcomes may be different in patients with obesity. And again, that study that I showed you at the beginning that compared the two is Dr. Ratner's group here. 224 patients, 187 underwent a Nissen, 37 had a Belzi with a 37-month follow-up. They basically concluded from the study that obesity adversely affects the long-term success of anti-reflux operations, given the high failure rate of anti-reflux surgery in obese patients, and intensive efforts at sustained weight loss should be made before consideration of surgery. So again, there were 26 recurrences in that group with 11% recurrence rate in the obese population, with much more than normal weight. Another study looking at meta-analysis of the outcomes of reflux surgery in obese patients as well. BMI less than 30 or greater than 30. I thought the important part here was the recurrence of reflux was significantly lower in the non-obese cohort. And they could be performed safely because the risks of morbidity, mortality, redo surgery was pretty much the same in the two groups, but there was a higher risk of GERD recurrence in this population. And clinicians and patients should be aware that obesity may adversely affect reflux surgery outcomes, and careful consideration should be given in the consent process with the optimal management of GERD. So again, one that meta-analysis over a really 50-year period almost, showing that there is more of a recurrence of reflux in this population. Another study from 2019 assists another meta-analysis looking at the effects of obesity on recurrence, and 12 studies qualified for the inclusion studies here, and showing a 53% increased risk of recurrence for patients that were obese. So greater risk of GERD recurrence, longer operative times in obese patients compared to non-obese patients. So definitely different in outcomes based on these meta-analyses of recurrence. And then I know there's another talk on this, but definitely comparing RAPS to bypasses in patients with obesity to find is there a better operation than Nissen to look at. And here's some studies that show that bypasses may be superior in the obese population. But here's Swanstrom's group, a comparison of objective outcomes following laparoscopic Nissen fundoplication versus laparoscopic gastric bypass in morbidly obese patients with heartburn. Both groups, the Demestre scores were normal after surgery, no significant difference between the two groups. Results of the study show that laparoscopic gastric bypass and lap Nissens are both effective in treating heartburn symptoms and objective acid reflux in morbidly obese patients. The health benefits of weight loss after laparoscopic gastric bypass should make this operation a procedure of choice. So basically they both work for heartburn and GERD, but again, the advantages of the gastric bypass are the other benefits that we see, like improvement in comorbidities and weight loss. Another, the impact of gastric bypass on reflux in patients with morbid obesity, a prospective study on the Montreal Consensus. And again, the conclusion here is that gastric bypass ameliorated GERD symptoms in most patients 6 months after procedure, resulting in quality of life improvement. Interestingly enough, there was more regurgitation post-gastric bypass. Whether this corresponded to reflux surgery or overeating was interesting, but definitely the preponderance of reflux symptoms preoperatively became regurgitation postoperatively. And another study, the same group, looking at the impact of gastric bypass on reflux. For most morbidly obese patients, in addition to causing weight loss, gastric bypass reduced GERD symptoms, improving reflux esophagitis, and decreased esophageal acid exposure for 3 years postoperatively. And again, there's a white paper that I mentioned earlier. Dr. Now, our session chair, is the lead author on this. It's surgical management of gastroesophageal reflux in the obese patients. And really, to summarize, the paper which came out earlier this year was there were 2 expert recommendations based on the evaluations. One expert recommendation was that a Roux-en-Y gastric bypass should be considered the gold standard approach to symptoms attributed to reflux in a population with a BMI greater than 35. And given the safety and performance of the Roux-en-Y gastric bypass, as well as the ability to positively influence the patient's metabolic comorbidities, it should be considered the benchmark for the treatment of GERD in obese populations. In fact, some have advocated for the worst of gastric bypass in the management of failed anti-reflux surgery, even in those with a BMI between 30 and 35. Obviously, they consider this controversial and requires more studies. But the conclusion relevant to this talk, based on this white paper, was that in the setting of obesity, Roux-en-Y gastric bypass is the procedure of choice for patients with GERD. This has been endorsed by prominent surgical and medical societies. And in the case of failed fundoplication, the Roux-en-Y gastric bypass is a reasonable approach for management of reflux, particularly if the patient is obese. So in conclusion, reflux is definitely increased in patients with obesity, and the pathophysiology is definitely multifactorial. A lot of different things go into the risks of reflux and the causes of reflux in a patient with obesity. I do think, based on what I presented today, that there's ample evidence that wraps can be performed safely and are effective, even long-term, in treating reflux in patients with obesity. Although most of the data are for patients with a BMI less than 40. And I think, given the fact that gastric bypass is effective for reflux, weight loss, and all the other improvements in comorbidities related to that, it definitely should be considered as an alternative to wrapping patients with reflux and clinically severe obesity. But in our practice, I think if I saw patients with a BMI over 35, under 35, I think it's safe to do a wrap in these patients. I think the evidence is pretty clear. I think over 35, we start talking about gastric bypass. I think if those patients were amenable to a weight loss operation, I think that's the route that we would take in our own institution. Certainly over BMI over 40, 45, a little bit less clear. And then the more significant obesity, I definitely think we would push patients towards a weight loss or bariatric operation first. And certainly in our practice, recurrent reflux after a Nissen in a patient with a BMI over 35, we almost always do a gastric bypass on those patients versus rewrap, unless they can't get approved or they absolutely refuse. So thank you for the opportunity. Hope to see everybody at SAGES in 2021.